Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of November 14th, 2022. Today, I'm going to talk about COVID variants, provide a monkeypox update, and talk about increasing respiratory illnesses in children, which includes right now RSV, flu, and COVID. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Here in Alameda County, we can see that our total cases over the previous 14 days starting to tick up a little bit. When I reported 2 weeks ago, we were at 1,698, and now we're up to 2,282. Hard to tell if this is a blip or if we're indeed starting to head upwards as we go into kind of a fall winter surge. So we'll just have to keep an eye on it, but definitely don't ever like it when it is going in the wrong direction. Likewise, our percent positive PCR tests is definitely heading in the wrong direction. We're at 7% positivity rate. Of course, both of these indicators are highly dependent on people going in to get tested. So we still have to take it with a grain of salt and take a look at other indicators, which include hospitalizations. Unfortunately, this is also going in the wrong direction, at least as it relates to overall hospitalizations. 2 weeks ago, we had 53 people in the hospital, 8 of those in the ICU. We're now at 77. So from 53 to 77 in 2 weeks. Not sure, again, if this is a trend. This doesn't really match up or line up with the increase of cases, because usually we see cases go up first, then followed by hospitalization. So once again, we're just going to have to keep a close eye on this to see if this is going to be sustained. But of course, we don't like to see this, which is wastewater. The quantity of SARS-CoV-2 concentration in our wastewater here in Alameda County is definitely heading upwards, it appears here. So all signs are kind of pointing in the wrong direction this moment. So we'll have to keep an eye on that. Some good news is that overall deaths, daily deaths in the United States are down a bit. So they were 351 when I reported 2 weeks ago, now at 264. So this is certainly an improvement. We'd like to see it come down further than this. This is still amounting to close to 2,000 a week, about 8,000 deaths a month. So this is still quite high, especially when we consider that we've been in a lull, essentially, of cases for some time now. So we just don't want to resign ourselves that this is as good as it gets. This is still too high. And every COVID death, we should consider a failure of some sort, most likely. Based on what we're seeing, this is primarily folks who are not up to date with boosters or did not receive timely outpatient treatment. So we can talk about having the tools, but we have to use those tools in order for them to actually make a dent in some of this. So we should really consider every death and really every hospitalization something to look into, something to investigate. Why did this happen? Did we do everything we could have so that we can better understand this and we can better intervene? Because this is we're still just losing too many people. And there's a couple of other items of concern as it relates to us heading into a surge here, or anticipating at least a winter surge. And that has to do with variants. This is something we know we have to keep a close eye on because of how they get around some of the tools that we have. And we can see that this BQ1 and BQ11 really have been taking over quite quickly. And so now overall, those two variants add up to about 44%. And so the thing that is concerning us about the BQ1 and the BQ11 is sort of how quickly it's out competing some of these other strains, meaning it's got some type of advantage. And what it appears that its advantage is it's getting around some of our prior immunity. So even for folks who had, let's say, the BA1 Omicron strain, those antibodies don't seem to be particularly protecting against BQ1 or BQ11. Also, it is getting around our monoclonal antibodies, which of course is a big concern because the monoclonal antibodies were one of the tools in our toolkit for treatment. But even more importantly, they were the only, or they are the only treatment that we have to basically protect people who are immune compromised or who cannot get vaccinated. So that pre-exposure prophylaxis basically is giving 6 months of protection against the prior strains, but now we're not so sure how that's going to hold up against the BQ1 and the BQ11. So for those who've already received Evusheld, we're not sure if we're going to be able to rely on that 6 months of protection anymore. And for those who are immunocompromised, we're losing this very important tool, and really hopeful that there will be some more, some new monoclonal treatments in the pipeline, because they have served an important function, but they're very, very specific. And so when the strains change, oftentimes these monoclonals have to change. And the question is whether there's going to be enough motivation among the pharmaceutical industries to go ahead and fill that gap. I certainly hope so, because as I said, it was filling an important role, and we hate to be losing tools when we are going into, our next surge. And I just wanted to point out, this is the map from 2 weeks ago. And if you take a look at region 9, which includes California, you can see that Kelly green plus the kind of dark olive green was really, under 24% a couple of weeks ago. Take a look now, and you can see that it's almost 45%. So it's definitely here in our region. And it's taking over quickly. And our region includes California, Arizona, Hawaii, and Nevada. But definitely BQ1 and BQ11 have made their move fairly quickly here. So we're going to have to kind of take stock and see what is going to be available to us. And I'll go over that in just a bit. But first, let me give a brief monkeypox update. So we have over 79,000 MPX cases worldwide. In the United States, we're at 28,947 cases, so almost 29,000 cases here in the United States. It really does look like we've come all the way off of our peak. The peak happened in August. Around that time, we were over 500 new cases per day. Now we're somewhere around 30 new cases per day. So it's certainly positive that we've come down off of the exponential growth phase. But 30 new cases a day is still a number of new cases a day. And I think there's just a couple of points I want to make here. One is that we've now had 11 deaths in the United States, and that's pretty concerning, considering that this should be a fairly self-limited, course. We have a vaccine, we have treatments. It can be quite painful and uncomfortable. But it certainly is concerning to see that we are seeing deaths. I went over this in a little more detail a couple of weeks ago about some of the more severe cases, but for the most part, our poor outcomes are happening in immunocompromised people, especially people with HIV that are not in treatment. So this is really highlighting what is another huge area of disparity and of challenge for us in healthcare and in the community, is that we need to make sure that people who have HIV know that they have it and that they're getting into treatment so that they can, first of all, not be in an immune suppressed state to where something like MPX could hit them and, cause some severe sickness and death. But also so that they can have their viral load suppressed and then not transmit HIV to others. So this is still a huge issue. This is still an epidemic, HIV. And really, I think HIV and MPX are two things that we should really consider looking at together, and so that we can address both of them simultaneously. Here in California, we've had 5,547 cases of MPX, and 229 have been hospitalized. That's about 4% being hospitalized. Again, that feels like a high rate, and I'm hoping that we see that come down. I also hope that we can get rid of seeing anyone have to lose their life to this. We now have availability of this vaccine, and you can see that the eligibility criteria here in Alameda County is fairly extensive. It even includes healthcare workers, but also includes anyone really who could be at risk. And so if you think you might be at risk, either because you're of yourself or your partner or anyone close to you, by and large, this is being transmitted by very close contact, but there have been some cases of transmission through linens, through holding a baby. It's been transmitted to children this way. So it is something that is still with us. But right now, I think the biggest push would be two things: get vaccinated if you're eligible. And second, any new lesions should be checked out and should be tested. And then just kind of one more plug for getting tested for HIV, treated in treatment for HIV, because those who are having the poorest outcomes are oftentimes immunosuppressed due to HIV out of treatment. So we'll continue to monitor that. And so now back to our respiratory illnesses. On November 4th, the CDC issued this health advisory that is basically letting us know that there has been an early and elevated incidence of respiratory diseases caused by different viruses. So we've had several unfortunate terms being used, like twindemic, tripledemic. I don't think that's particularly going to be useful, but I do think it's important that we understand that we are having sort of a number of respiratory illnesses that are hitting at the same time. This isn't unheard of, but some things are slightly unusual. So one is the RSV that I've been talking about, respiratory syncytial virus. We have an RSV season every year. It's just early this year. Also, the flu virus, influenza, does seem to be hitting us hard and a bit early this year as well. We have different types of flu epidemics each year, and so I'll get into some of the details on that. But between RSV and flu on top of SARS-CoV-2, we are looking at a few things. One is that these can be contracted at the same time. So you could indeed have two illnesses at the same time, which certainly could have you in much worse shape than just one or the other. And also the healthcare system is already under stress in many parts of the country and the world from all of these respiratory illnesses happening at one time. And so we really need to be thinking about how to prevent the spread of respiratory viruses. And much of the interventions and mitigation strategies are going to be the same as what we've been doing for COVID. But unfortunately, we dropped a lot of those things. So it's really important, especially as the weather gets colder and we start to do more things inside or have a harder time keeping the windows open and so on, that we're paying good attention to indoor ventilation, because that's going to help prevent the spread of all of these things. We're also going to want to stay up on vaccination. I'll get into a little bit of that in a second here. Antiviral treatment or even prevention if it's appropriate, which it is for some groups of people. And so this health advisory went into a lot of detail. So for those of us in healthcare or who are interested, I have put the link in the post, and it goes through kind of what we need to be doing for each of these. But I think we also just need to be looking at it overall and making sure that we're not running into trouble in terms of outbreaks within our schools, in our workplaces, and otherwise just trying to avoid our hospital systems from getting overwhelmed. We're already hearing reports from other places in the country as well as in Canada that their pediatric units are getting over full, and they're actually having to move children to adult hospitals. So this is not something we ever want to see. It is concerning, but capacity within pediatric units in particular can be limited, as I've reviewed previously. So this is just something that we need to be vigilant about. We can see here that in the United States, our detections of RSV are just continuing to sort of head straight up. And so, most people have just a respiratory illness for a week or so. But certainly our little ones in particular are at increased risk. In fact, sadly, we just received our first death of a child under 5 years old. This child had flu and RSV together. And so this was reported by the California Department of Public Health, and very sad to hear this, and definitely want to do what we can to prevent it. Right now, there is no vaccine for RSV, but this is something that's been worked on for some years. And there's actually a candidate that is in development. It's being tested right now, and it is suggesting that by vaccinating pregnant people against RSV, that can actually protect the newborns from infection. So we'll keep an eye on this. Hopefully this is an innovation that will be coming to us soon. In the meantime, there are certain groups of vulnerable little ones that may be eligible for actually monoclonal antibody treatment. And so any little ones that are born premature, maybe have cardiovascular or lung infections or lung conditions during this time may be eligible for that. So that's something to certainly be aware of. And flu is definitely hitting us hard already, hitting us early. We have not seen hospitalization rates like this from influenza since the swine flu pandemic. You may recall that was in 2009. And so this is, we're seeing quite a burden of hospitalization from flu already. Positivity rate is at 12.8%. So that went up quickly. So far this season, there have been an estimated 2.8 million cases of influenza, according to the CDC. 23,000 hospitalizations from influenza, and 1,300 deaths from flu. 3 of those were children, according to the CDC. The 1,300 deaths that's so far this season. Of course, we know that we're losing this many people every single week from SARS-CoV-2. So even though it's not always helpful to compare these things, it's definitely important that we keep them in perspective and understand that this is happening on top of our SARS-CoV-2 pandemic. So this is where we start to get concerned about our overall resources and our ability to meet the needs. And on November 11th, we got this morbidity and mortality weekly report that was taking a look at hospitalizations among infants less than 6 months of age for COVID. And basically, bottom line of what this is showing here is that among infants less than 6 months old, now remember, our less than 6 months old are not eligible for the COVID vaccine. And that among that group, when they sort of have taken a look at hospitalization rates, that we're seeing that the hospitalization rate for under 6 month olds was similar to that in the adult age group of 65 to 74 years old. So the under 6 month old babies were being hospitalized at a similar rate to our 65 to 74 year olds. Very, very concerning. This is higher than all the other pediatric age groups. So really want to urge us to protect our littlest ones, the ones that can't be protected by getting vaccinated themselves. And how can we do that? So a few things. One is pregnant moms get vaccinated. There is some evidence that that protection is passing to the infant. There have been no reported issues with pregnant moms getting vaccinated. In fact, we know that pregnant people who get SARS-CoV-2 are much more likely to get very ill, to go to the ICU, and to have poor birth outcomes and poor maternal outcomes. So we want all pregnant moms to go ahead and get the SARS-CoV-2 vaccine, and that can even protect our newborns when they're born, so that we can hopefully avoid this increased hospitalization among our under 6-month-olds. And this graph is just showing just that. You can see that that solid black line is our under 6-month-olds. This is hospitalizations from SARS-CoV-2. So early on and all along, those hospitalization rates were lower than all the other groups, but now you can see that it has gone up, and it is looking similar to that 65 to 74-year-old age group. So this is not okay. These are our littlest, most vulnerable people. So aside from pregnant moms getting vaccinated, and you can see here this advisory from the CDC, vaccination during pregnancy helps protect pregnant people and their babies. And we want to protect the babies also by ensuring that sick people are not coming around them, that ideally they're only going to be around people in their bubble. And really, this was something that we used to advise even before COVID. You don't want to have people who are sick or people who are outside the bubble coming around the little ones when they're too young, because they are still vulnerable. So let's do what we can to protect them. And when it comes to the flu, just wanting to point out here, not only the positivity rate, which as I mentioned is 12.8% this week. You can continue to monitor this on a weekly basis, but you can see it's going up quite steeply. Mostly this is influenza type A. And you can also see the map of the United States, where a couple of weeks ago, there wasn't anything in the very high category, but now you can see here in the South, kind of in the Southeast, we're seeing some very high rates of flu transmission. And on the West Coast here, California is the only state that's in a high transmission area. And again, we've reported already our first child death. So this is something we should not take lightly. This is something that is on the rise. And we have vaccines for influenza, and those are available for children 6 months and up, well, children and adults, everyone 6 months of age and up. The good news is that the flu vaccine is well matched to the strain that is circulating now. We know that we don't have that. That's not the case every year, but we did a good job this year, and it is matching. But the uptake of the flu vaccine is too low. The uptake of the COVID vaccine is too low, and especially in our little ones. So we know that with the flu, it's a little different than COVID, where COVID is really affecting our elders much more severely. With flu, it is elders and our babies, so extremes of age. And we're seeing that now a little bit with COVID. So we are always concerned with our extremes of age, the very young, and our older folks, and that is still remaining the case. So right now, what we have is a situation where our uptake of flu vaccine and COVID boosters are nowhere near where they need to be. And yet we have a lot of vulnerable people, and people who are getting more vulnerable by the day because their original vaccine series has worn off already. So we want to make sure that people understand that just because you got your primary series, that's all wearing off by now. And if we're going to be protected through this winter surge, the best thing you could do is get that Omicron or bivalent booster shot. So if you've not had COVID or a COVID vaccine in the last 2 months, strongly recommend getting that bivalent booster so you can protect yourself and your loved ones, particularly throughout this holiday season where it's starting to get cold and where we know a lot of folks are going to be traveling and gathering. So please be careful out there. Don't forget about your flu shot. If you want, you can get it on the same day as your COVID shot, or you can space it out, up to you. Just might have some more side effects if you do it together, but then you'll also just get it over with. But either way, it's past time to get the flu shot now in order for it to really protect you throughout this flu season, which has already started. You really need to go ahead and get that flu vaccine as soon as possible. And as it relates to SARS-CoV-2, really wanting to emphasize that outpatient treatment is critical, and we are losing one of our tools, which is the monoclonal antibody treatment that will likely be obsolete soon, and maybe we'll get replaced by another one, but we'll continue to monitor that. But for right now, really our top choices for outpatient treatment for SARS-CoV-2 are Paxlovid, the pills, must be started as soon as possible, but definitely within 5 days. Second choice, remdesivir, that is IV. And this is a perfectly good option for someone who cannot take the Paxlovid, maybe because of poor kidney function or because of medication that cannot be stopped. The other good thing about the remdesivir is that it goes all the way down to our tiniest ones, and it can be started within 7 days. It is 3 days of going in to get an IV dose of the remdesivir, but that is much better than getting sick enough to go to the hospital. So what I'm going to suggest is that if you are in the definitely over 65, or if you're under 65 but with underlying conditions, that you find out now if you're going to be able to take Paxlovid. We're still hearing a lot of people getting denied Paxlovid because of medications, and oftentimes those are medications that can just be held. Cholesterol medication is the perfect example. You can hold it while you're on the Paxlovid and for several days after that, and you will have a 89% reduction of hospitalization or death. Well worth it. There are some medications that might be a little bit trickier in terms of whether you need to hold them or switch them to something else. This is why the plan needs to be laid out now, not when you are scrambling. I've been spending a fair bit of time on the weekends trying to help folks who cannot reach their doctor in order to get them connected to treatment. And really, it should not be like this. This should be a treatment like anything else, where it is time sensitive. You need to know ahead of time if it's something you're going to take, and your doctor should be able to prescribe it for you. But if not, we still, for now, have some options as far as test to treat programs within the pharmacies and so on. We know that this may be going away soon as the government looks to commercialize the COVID response. So the concern now is low vaccination rates of SARS-CoV-2, low vaccination rates of flu, and poor uptake of treatment, outpatient treatment for SARS-CoV-2. If we do our best in terms of getting those booster rates up and getting treatment when it is indicated, then we will not be seeing 200, 300, 400 people a day dying now, and we'll be able to mitigate the winter surge, which we anticipate. We will have a winter surge. It does not have to lead to thousands of deaths a day like our prior surges have. It does not have to lead to thousands of hospitalizations a day if we are using the tools that we have. And I went into this a couple of weeks ago on the briefing about the disparities in prescribing, but we are seeing that Black and Latino populations in particular are receiving far fewer prescriptions, even when they're seeking care for SARS-CoV-2, 30, 35% fewer prescriptions. So this is something, it's not acceptable, but we just need to know this so that we can advocate accordingly and make sure that if you're eligible for treatment, you get it. And so in the meantime, we are going to make sure we're availing ourselves of the vaccination and booster. We're doing our best to be in well-ventilated spaces with good air filtration. Open up those windows if you can as well. Definitely want to wear high-quality filtration masks. All masks are not created equal. Really, if you're in a space where others are not masking, you are going to have to wear an N95 or at least a KF94 or KN95 to get adequate filtration to filter out those SARS-CoV-2. Testing and treatment, know where to get tested. If you're someone who's eligible for treatment, please get a PCR test, because that is how you're going to detect it early. We're still seeing that the antigen test could be negative for several days, and you're losing time at that point that you could be getting treated early and trying to shut this thing down from replicating in your body and entering into the more severe phase. And what I want to say about that is something that I'm still seeing that a lot of people have some misconceptions around, which is that you're not waiting to see how you feel with COVID. That first week is similar to a cold or flu. We're actually seeing some people having GI symptoms, nausea, vomiting, things like that. But you can certainly get through that first week feeling okay. The second week is when we start to worry. That is the inflammatory phase. That is when things can really take a turn for the worse, and where you can end up in the hospital with multiple organs having issues because of this inflammation that can happen, and it can affect just about any organ in the body. Notice I said that that happens in the second week. So that's typically when people are ending up in the hospital, needing to get on oxygen and maybe other treatments. But when do you have to start outpatient treatment? In the first week. So if you wait to see how you feel from the first week and don't get yourself treated, it may be too late. You may already be hospitalized, and in that case, we can no longer do those outpatient treatments, and now you are really rolling in the dice a bit more in terms of how you're going to fare. So if you want to reduce your chances of hospitalization and death, it is booster and it is outpatient treatment in week 1, not wait to see how you feel. It has nothing to do with how you feel. It has to do with whether you qualify or not. So if you don't have a primary care doctor, please get one. Know how to reach them before you need treatment. Have a treatment plan before you need treatment. And for now, if you are immunocompromised or unable to be vaccinated, we still are recommending Evusheld. Not sure how long that's going to be the case, but for right now, that is the case. And if you are at risk of progression to severe illness, make sure you have a plan to get Paxlovid, get treated with that. And if you're not able to take Paxlovid, you need a really good reason. Your doctor needs to give you a really good reason. Make sure it's not that you couldn't just hold your medication. And if you're truly at risk, then you're someone who may be eligible for remdesivir if Paxlovid is not appropriate. And of course, as always, please maintain a nice, nutritious, balanced diet, get some exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. Thank you so much for joining us. We'll see you again next Tuesday at 10 a.m.